So, welcome this evening. Today I'm going to be speaking about neonatal sepsis. My name's Dr. Robyn Fyvie. I was a past community service medical officer at Rahima Musa, Mother and Child, in 2024, and now currently working as a GP. So, what is neonatal sepsis? It's basically a clinical syndrome that manifests with non-specific signs and symptoms resulting from a bacterial blood infection that occurs within the first 28 days of life. It can rapidly spread and affect multiple organs and systems, including the meninges, which would be meningitis, the lungs causing pneumonia, bone, which would be osteomyelitis, and then things like the kidneys, like pyelonephritis, but that's just to name a few. It's a leading cause of morbidity and mortality in newborns, particularly in lower and middle income countries, and it's responsible for a third of neonatal deaths globally. So, what causes neonatal sepsis? It's basically divided into two groups, and it's defined differently by some experts, but I've kind of put both definitions here. So, the first one is early onset neonatal sepsis. It is typically occurring within the first 7 days of life, with some definitions narrowing this to the first 72 hours of life. It is spread via vertical transmission from the mother to the fetus during the intrapartum period, and can occur via hematogenous transplacental spread from an infected mother or via ascending infection from the cervix. And organisms that colonize the mother's genitourinary tract may be acquired by the neonate as it passes through the colonized birth canal delivery. So common organisms would be things like group B streptococcus, E. coli, coagulase negative staphylococcus, Haemophilus influenza, and Listeria monocytogenes. Of newborns with early onset sepsis, about 85% present within the first 24 hours, 5% at about 24 to 48 hours, and then a smaller percentage within 48 to 72 hours. So basically, you can see that majority are presenting within quite early on in the first 24 hours. And onset is most rapid in premature neonates. Late onset neonatal sepsis basically occurs sort of after 7 days of life, up to 28 days of life, or more than 72 hours, and in some cases can extend up to 90 days of life. It's spread via horizontal transmission, via microorganisms from the hospital or community environment, and bacterial organisms that are quite common are coagulase negative staph, S. aureus, E. coli, Klebsiella, Enterobacter, Acinetobacter, Candida, and then other things like Pseudomonas, GBS, Serratia, and anaerobes. And the peak incidence is between 15 to 17 days of life. And then in general, so I've mentioned the bacterial organisms, but it can also be caused by viruses such as adenovirus, enterovirus, and Coxsackie virus. And also we need to remember about sexually transmitted diseases such as gonorrhea, syphilis, CMV, HIV, because these can also be spread through from the mother to the child. In early onset sepsis, pneumonia is the most common, and then meningitis is more common in late onset sepsis. So what are the risk factors for neonatal sepsis? Again, I've split it into the two categories. So for early onset sepsis, we have to think about the risk factors that are implicated in that are implicated in neonatal sepsis, and they reflect the level of stress and illness experienced by the fetus at delivery, as well as the hazardous uterine environment surrounding the fetus before delivery. So the ones in bold are the more important ones, but there are quite a few of them. So it's maternal GBS colonization, premature labor, premature rupture of membranes, prolonged rupture of membranes, intrapartum fever, chorioamnionitis, and low birth weight. And early onset sepsis is actually 10 to 20 times more likely to occur in a premature, very low birth weight infant. So those are quite important risk factors. Then in late onset sepsis, it's prematurity, central venous catheterization, especially for a duration of longer than 10 days, urinary catheterization, chronic mechanical ventilation, failure to advance enteral feeding, nasal cannula or CPAP, and then any gastrointestinal tract pathology. So I wanted to just discuss a few of the more important risk factors in more detail. So GBS colonization, there's 9 serotypes, with 1, 2, and 3 being associated with neonatal GBS infection. So basically, the GBS organism colonizes the maternal gastrointestinal tract and birth canal, and then colonization at delivery is associated with the neonate getting infection. Intrapartum chemoprophylaxis, which we'll speak about at the end, for women with positive GBS culture results, has shown to reduce transmission of the organism to the neonate during delivery. And then secondly is premature rupture of membranes or prolonged rupture of membranes. This may occur in response to an untreated urinary tract infection or birth canal infection, but also from other risk factors such as previous preterm delivery, uterine bleeding in pregnancy, and heavy cigarette smoking during pregnancy. Rupture of membranes without other complications for more than 24 hours before delivery is associated with a 1% increase in the incidence of neonatal sepsis. However, when you actually add on chorioamnionitis to that, the incidence of neonatal infection increases fourfold. Then the last one is premature labor. So preterm infants are more likely to require invasive procedures such as umbilical catheterization and intubation. And this basically increases the risk of introducing organisms from the skin and environment, such as coagulase negative staphylococcus or things that are on the skin. Premature infants also have less immunologic ability to resist and combat infection, so they're more susceptible to the infections caused by things, as I said, like CNS, and they can then cause more severe sepsis. This is a graph that I found. It's based in the USA. It was published by the American College of Obstetrician and Gynecologists as well as the American Academy of Pediatrics. And it basically shows the incidence of early and late onset invasive GBS disease. And you can see how the implementation of prenatal screening and treatment protocols for GBS has resulted in a dramatic decrease in the incidence of GBS sepsis. So you can see it was the first guidelines that were at about 1993, and then again in 1997, where we've had these huge drops again in 2003. And this has also changed the epidemiology of early onset sepsis, because if you're getting less GBS causing the neonatal sepsis, there might be then other risk factors for neonatal infection. So this is just a stats that I found. And despite significant global efforts to reduce neonatal mortality over the past 3 decades, neonatal death remains very high. And in 2017, South Africa recorded 18 neonatal deaths per 1,000 live births. The global mortality rate is estimated to be between 17.6%, with 42% of those occurring within the first 7 days of life. And projections suggest that between 2018 and 2030, 27.8 million children will die within their first month of life worldwide. So if we talk about more specific studies that were done in South Africa to give us our own statistics, the first one was a study done called Neonatal Sepsis, highlighting the principles of diagnosis and management by Coetzee et al. In 2017. And it basically showed the overall incidence of neonatal sepsis being between 8.5 to 10% of live births, with late onset sepsis accounting for the majority of these infections. Mortality rates for neonatal sepsis varied, with early onset sepsis mortality being between 24.2% and 40%, and late onset sepsis mortality between 19.7% and 22.5%, which result in an overall mortality rate of 20.8 to 23%. And it also showed that gram-negative sepsis was responsible for the majority of deaths. Then the second study was a study done called Prevalence and Presentation of Neonatal Sepsis at a Pediatric Emergency Department in Johannesburg. And this was done in 2022, so it's a little bit more recent. And it included a study of 210 neonates, of whom 20.5 were diagnosed with neonatal sepsis. Of these, 44.2 presented within the first 72 hours of life, which shows that early neonatal sepsis is quite high. 4 neonates, which is 9.3%, died prior to hospital discharge. And they also found some other factors that showed that were associated with neonatal sepsis in the study. So, maternal factors such as maternal employment and HIV exposure, and infant factors such as preterm birth, low birth weight, and any signs of illness such as lethargy, dehydration, poor feeding, irritability, fever, vomiting, and respiratory distress. And then lastly, feeding factors. So things like not being breastfed was also quite a significant factor that increased the risk for neonatal sepsis. So if we move on to clinical presentation, if you learn anything from this presentation, it's that the diagnosis of neonatal sepsis is not straightforward at all. And infants, especially premature infants, present with very non-specific, subtle signs, and we need to have a high index of suspicion at all times. The initiation and continuation of antimicrobials in these situations relies on good clinical judgment, and the need for empirical antimicrobials is driven by the existence of these risk factors for early onset sepsis and then also the clinical symptoms and signs of late onset sepsis. So if we look at the history, we need to be basically being aware of these risk factors just prepares the clinician for early diagnosis and identification, and then obviously finding the effective treatment that then can reduce morbidity and mortality. So if we look at maternal factors, it includes things like GBS colonization, maternal infections, poor prenatal care or follow-up, chorioamnionitis, fever during labor, chronic medical conditions, or use of medications. Then things like intrapartum factors, so preterm labor, prolonged rupture of membranes, C-section, any invasive procedures during delivery or use of instruments, and then multiple gestation. Neonatal factors, including prematurity, low birth weight, invasive devices, resus at birth, and congenital abnormalities. Environmental factors, so any recent hospital admissions, and then also postnatal, so any breastfeeding issues or issues with malnutrition. And then some important symptoms to ascertain on history. As I said, these babies can really have anything. So you just have to be very careful of who you send home. So things like fever, jaundice, cyanosis, lethargy or irritability, which is quite an important one because the parents might present with this child that just doesn't want to stop crying, and you think, oh, it's just colic or it's just something else, but you just really need to have a high index of suspicion if this baby is crying incessantly and just won't calm down. Poor feeding or feeding intolerance, tachypnea or difficulty in breathing, apneic episodes, seizures or abnormal posturing, and then abdominal distension or vomiting. So if we move on to presentation, as you can see, it's also there's a very broad range of ways that a baby or an infant can present. So firstly, on general exam, we need to do good vitals. So we need to see if they've got a fever, because you can get quite severe temperature instability. So they can either present with a fever or hyperthermia as well as hypothermia. They can look jaundice or cyanose as well as having like a mottled gray skin color. They can have a bradycardia or a tachycardia. And then they also get glucose instability, so hypo or hyperglycemia. So their HGTs actually need to be checked quite often. Then they can have signs of meningitis or looking at their CNS system. So things like stoop and irritability. Again, I said incessant crying and things like that need to be a red flag. Coma, seizures, bulging anterior fontanelles, extensor rigidity, focal cerebral signs, cranial nerve signs, nuchal rigidity, central apnea or periodic breathing. And then also signs of respiratory distress, so tachypnea, retractions, cyanosis, grunting, and then apneas. And then also looking for signs of shock, so hypotension, poor perfusion, pale, cold, clammy skin, capillary refill times of more than 2 seconds, and metabolic acidosis. So if you're doing a blood gas, you might see that. GIT, so vomiting, abdominal distension, and hepatomegaly. And then you might even have features of bleeding if they go into a DIC or something like that. And you may see frank bleeding or petechiae or purpura that appears. So again, how do we approach it in the ED? So our first port of call is to stabilize the patient, and that's always to follow our ABCs. So looking at airway, is the airway patent? Do they have a decreased level of consciousness? Are they able to maintain their own airway? And if not, we need to find ways to protect the airway. That goes again then with breathing, because if they have features of respiratory distress or respiratory failure, as well as apneas, we need to think about giving them supplemental oxygen, or they may even need intubation and mechanical ventilation. Looking at circulation, so do they have features of hypertensive shock? We need to try and get IV lines up as quick as possible. If we're not able to get them up, we need to think about doing an IO just for that sort of first stage of the resus, and then trying to get a peripheral line up. We may even need a central line if we need things like inotropes at a later stage. But we also just really need to be careful of fluid overload, because these small babies don't need as much fluid as adult or bigger children. And then disability, so assessing the level of consciousness, are they awake and looking at you, or are they babbling? Okay, they might not be at 1 month, but interacting with you, or are they just reacting to pain, or are they just unresponsive completely? Checking pupils, checking features of raised intracranial pressure, and then most importantly, testing and treating hypoglycemia, because that can be changing their level of consciousness. Exposure, so keeping the child warm. Remember that children are not able to maintain their body temperatures very well. So we need to keep them under radiant warmers, or somewhere where it's warm, where there's not a lot of cold air coming through. And if you're doing procedures on them, we need to make sure that other parts of the body are being kept warm. And then don't ever forget the glucose. If the child is unstable or you're in doubt, please call for help. This actually should be before the ABCs and stabilize. You should be calling for help. So whether that's a colleague that needs to help you stabilize, or if it's an emergency, the ED consultant, or the pediatric reg, you need to call someone for help, because these babies are small and they can deteriorate quickly. Secondly, what investigations we need to do. So with neonatal sepsis, the gold standard is obviously confirming the sepsis is with a positive culture from a site such as blood, CSF, or urine. So we, at the end, basically need to do a full septic workup. But what can we do at the bedside or in the emergency department? Basically, we can do a urine dipstick, see if the infection's coming from the urine, which we can then send for an MCNS. Again, finger prick HCTs, checking their glucose. We can do blood gases to check their acid-base statuses, check if there's any problems with their potassium, sodiums, and all those kinds of things. And then we also need to make sure we're doing an ECG. POCUS can help us in septic patients, because it can help us to maybe find a cause, or try and rule out something. We can assess fluid status, and it can guide our resuscitation, and it can also help us to perform procedures if we're struggling. So moving on to lab tests, this will more be like for the peds doctors, but you might need to be thinking about doing things like a blood culture before giving, or before giving antibiotics, or doing an LP before giving antibiotics. So we may need to know about this. So urine, doing an MCNS, bloods, doing a full blood count, a differential white cell, a blood culture from a sterile site, a UNE, and a CRP. And then if you suspect DIC, you need to do screening for that. And then an LP. So the thing at the bottom is predominantly for a bacterial infection of the CSF. But basically you would get an increased white cell count, predominantly polymorphonuclear neutrophils. You get an increased protein, a decreased glucose, and then positive culture and PCR results. And then radiological. So in these kids, in these infants, because they're not always able to localize the infection, we need to be doing complete septic workups, which again includes the bedside lab tests and radiological tests. So we need to check the chest x-ray. Is it coming from a pneumonia? An abdominal x-ray, is it coming from something like a necrotizing enterocolitis? If they have CNS symptoms, we need to be thinking about doing a CT or an MRI brain. But in infants, we can also do a cranial ultrasound, which can reveal a meningitis with evidence of a ventriculitis. abnormal parenchymal echogenicities, extracellular fluid, as well as chronic changes. So after we've done investigate, well, depending on if how PEDS is involved and if we've taken our first specimens for our cultures, we need to start early empiric antibiotics. So these are according to the EML guidelines. The first line, obviously all of this is based on the antibiotic sensitivity and resistance profiles of our hospitals or communities. And we need to obviously be doing cultures before starting antibiotics. But the first line would be something like gentamicin, which is an aminoglycoside. And they say 5 to 7 days IV. I've given you there the dosages that we would need for less than 32 weeks of gestation or more than 32 weeks of gestation. But we need to remember that aminoglycoside has the potential to produce ototoxicity and nephrotoxicity and should be used with caution. So we need to try and monitor the serum drug levels if possible. And then children, not really for us, but for PEDS, it's important that these children get audiology and renal function testing before they go home so that we can see if there's any toxic effects from the medications. So it's gentamicin plus ampicillin, which is also intravenous for 5 to 7 days. And you can see there's a table there that shows you what the dosage is for the gestational age or the postnatal age. Then moving on to the second line. So if the child is deteriorating on the first line regimen and there are no positive results, then we can change to something like piperacillin tazobactam IV for 7 days. And then I've also given you the dosages there in the table, depending on their postnatal age. And then you also add amikacin to that, which is 15 milligrams per kilogram per dose, 24 hourly. Therapeutic drug monitoring should also be done when available. And then shorter durations of therapy should be used when there's no culture confirmed infection and the child shows clinical improvement. So this is just a nice table that shows you basically once you've got your culture back and wherever the area is that you found it. So if it's a meningitis, then what is the bug and what is it susceptible to, and then how long we should be treating. Okay, so once we've gotten over sort of the bigger things and once the baby's stabilized, we've gotten help, we've done the investigations, and we've started empiric antibiotics. As I said, we need to ensure a neutral thermal environment, so the babies need to be put in a radiant warmer or an incubator because they really struggle with their thermoregulatory mechanisms. And then obviously start an infusion with an IV fluid that's appropriate depending on if they're hypertensive or not, and depending on the systemic effects of their sepsis. But we also need to be monitoring for signs of fluid overload, so things like wheezing, shortness of breath, and checking for things like hepatomegaly. They may need blood products. So if they start going into severe sepsis where they have things like a DIC, they may need packed red cells, platelets, and fresh frozen plasma as indicated. We also need to remember that they need adequate nutrition in order to fight these infections. So if they're not able to, usually they won't be able to eat by themselves, so they may need an oral or nasogastric tube feeding. Or if it's very severe, they might need a TPN, but a dietitian referral is always important. And don't forget that we need to see the child as a holistic being that's got caregivers and family. So we need to have ongoing counseling of the family. They may need a social worker and psychology referrals. And then we need to have a disposition plan. So if the child is still in the ED, what is the relevant speciality? Is it a PEDS problem? Is it a pediatric surgery problem? Is it an osteomyelitis that needs orthopedics? And then also depending on how unstable the child is, we need to think of high care or ICU. This is just something to talk about with regards to therapeutic ranges. So trying to keep everything basically normothermic, normotensive, etc. So the PaO2 we need to maintain between 60 and 80 millimeters mercury or SATs of 90 to 95%. If their PaCO2 goes above 55, we need to think about ventilatory support. Body temperature, we should be maintaining between 36.5 and 37.5, and that's axillary or anterior abdominal wall. And remember that on the right-hand side is where the liver is, so try and keep it on the left. Blood glucose levels between 2.6 and 6.8, acid-base statuses and pHs of 7.35 to 7.45, hematocrits of 40%, and then adequate urine output and fluid balance of 2 to 3 moles per kilogram per hour, and then basically just maintaining normal vital signs, respirations, electrolytes, minerals, and just trying to get the baby better. I wanted to touch a little bit on emerging antibiotic resistance and why antibiotic stewardship is important. So basically, antibiotic resistance occurs when the bacteria evolve mechanisms to resist the effects of drugs that once killed or inhibited them. So this makes infections harder to treat, leading to longer hospital stays, more doctor's visits, and increased mortality. So superbugs like MRSA or methicillin-resistant Staphylococcus aureus and CRE are examples of resistant bacteria that pose significant public health threats. And the role of antibiotic stewardship is basically to have this coordinated program that promotes the appropriate use of antibiotics, which aims to improve patient outcomes while reducing the adverse effects of overuse and misuse. It includes prescribing the right antibiotic at the right dose for the right duration and avoids unnecessary prescription. So it basically helps to preserve the effectiveness of antibiotics. So how do doctors play a role in this? It's basically by trying to make an accurate diagnosis, de-escalating antibiotics once we've cultured a specific bacteria, and then using the correct dosage for the correct duration and not overdoing it. So what is the prognosis and the long-term complications of neonatal sepsis? So with early diagnosis and treatment of neonatal sepsis, most infants will not experience long-term health problems. But if early signs or risk factors are missed, mortality obviously increases. So residual neurological damage occurs in 15 to 30% of neonates with septic meningitis. And mortality from neonatal sepsis may be as high as 50% for infants who are not treated. And obviously, infection is a major cause of mortality during the first month of life, and it contributes to 13 to 15% of all neonatal deaths. Low birth weight and gram-negative infections are associated with worse outcomes. Then looking at the complications, so obviously especially when you have meningitis, you'll have neurodevelopmental delays, so you can have cerebral palsy, cognitive and learning disabilities, as well as speech and language delays. So we need to get the allieds and the multidisciplinary team involved as soon as possible. Hearing loss, so both from the meningitis as well as the use of aminoglycosides. So as I said, we need to be testing the hearing and they need to get an audiology test before leaving the hospital. Visual impairments and blindness, chronic lung disease, bronchopulmonary dysplasia, so basically if they've been on mechanical ventilation for long, cardiac, so heart failure and arrhythmias, growth impairment and failure to thrive. That's why we need to make sure that we are getting dietitians involved early and we're giving them appropriate nutrition. GIT, so we can get necrotizing enterocolitis, intestinal obstruction, and short bowel syndrome. We can also get renal effects, so things like AKI and chronic kidney disease. And then we can also get bone and joint complications. So if, say, the bacteremia spreads or if that was the start of where the sepsis occurred, we can also get things like osteomyelitis and septic arthritis. And then we should really think about the psychosocial and emotional effects of this, not only on the child, but also on the caregivers and the parents with the long-term hospital stays. So lastly, I just want to touch on the prevention so one of the risk factors is obviously GBS. And in South Africa, screening and treatment protocols are essential in reducing the risk of neonatal sepsis caused by GBS infection, especially the early onset neonatal sepsis. The protocols vary slightly across institutions, but the general approach involves screening women for GBS colonization and then providing the appropriate treatment to prevent transmission. So prenatal screening is not universally mandatory, and I don't think it's done very well in South Africa, but it's recommended for high-risk pregnancies or based on the risk factors. So how we do this is via vaginal rectal swabs, which is the standard screening, and it's ideally done between 35 to 37 weeks because obviously that's just before most women are going to be giving birth. Then the swab is sent to the lab, and then through PCR or polymerase chain reaction testing, we basically get a result. So if the woman is positive, so GBS colonization positive, or has risk factors, we can give IV penicillin G prophylaxis. And there's also alternative antibiotics for penicillin allergic women. And then obviously monitoring and management, so close monitoring of the neonate afterwards when they have been delivered, especially the ones at higher risk, and then initiation of empiric antibiotics early if infection is suspected. And that's the end. Thank you for listening to the talk. If you have any questions or any comments or anything, please don't hesitate to ask.